Welcome to Clean Talk, another episode of Clean Talk. I am your guest host today, Pablo Gonzalez. You may have seen me on a couple other past shows. Brad's indisposed out of the country today, so you got me. But I'm really excited to talk to William Lewis today, who is the General Counsel, Chief Security and Privacy Officer at More Health, innovating around telemedicine and all the benefits that's going to be able to provide the healthcare ecosystem here in the United States and internationally. Will, welcome to Clean Talk, man.
Hi, thanks for having me, Pablo, and thanks to Seal Shield for hosting this.
Yeah, man, we're pumped you wanted to join here, joining us from Silicon Valley, right? Like you're like in the thing, right? Innovating tech, healthcare. Let's kind of get started with this idea. What is More Health working on? Like, what is the problem that you're solving? And let's start talking about how that can help, the healthcare system, the mission and everything. But tell us more about More Health.
It'd be my pleasure. So about 10 years ago, Hope Lewis, our founder, was working as an attorney in Beijing. And in China, the way that relationships are built are different than in the US. In the US, we tend to start with a high level of trust with our partners, and then your actions can erode that trust or maintain that trust. Whereas in China, people tend to start at a very low trust level, and then trust is built up over time. And she'd gotten to the point where she had high trust levels with her clients. And one of her clients, their child was diagnosed with a very rare form of cancer. And they were able to put together all of the best physicians in China into a hotel room to take a multidisciplinary approach to diagnosing her, to try to figure out if there were ways that they could treat her. And the doctors all came up with the same response, which was, you need to start some sort of hospice care for her. There's nothing that can be done. But fortunately, Hope had some contacts at UCSF Medical Center in San Francisco. And they said, you know what, you should come here, see if there's anything that we can do here. There's been new advancements in care. So Hope flew to San Francisco with the child's medical records. And sure enough, there were new treatments that they were able to use to treat the child. And she's now a healthy 12-year-old. She's doing great. But the thing is, it took over a year of treatment, and it cost the parents about $2 million. Now, this really stunned Hope because she thought that she was making a good wage in Beijing as an attorney at a big firm, but there was no way that she could afford that kind of care for her family members in the event that they had such a critical diagnosis. So she started working with her high school classmate, Bo Hu, to develop a way to bring the expertise of US physicians to people in China and around the world. And that's where More Health came from, just to create greater access to high levels of care for everyone, for as many people as possible. Now, 10 years later, we have partnerships with most of the top academic medical centers in the US, as well as great academic medical centers in Europe and Japan. And we have relationships with many of the largest hospitals in China through our Chinese affiliates. We've helped over 10,000 people secure great diagnoses. And physicians love using our platform that we've developed to facilitate this so much that US hospitals are now using our service to deliver second opinions to their patients, and even using it to collaborate internally.
Love it, man. I love when I get to host Clean Talk, because I get to me, the innovations inside of healthcare and the scale and the impact of what it can help is really awe-inspiring. I love a founder story that is solving her own problem that then goes on to be mission driven and solve it for others. Reminds me a lot of how Seal Shield's mission of solving for hospital acquired infections is just like interlaced with everybody that's been affected by it. And I just think that that's such a powerful mechanism. I want to join you. I want to welcome you if you're joining us today. We've got 11 folks with us on the call this far. So Bill, Brandy, Derek, Jordan, Lyrica, Mark, good to have you. Make sure that you use the Q&A. Make sure that you use the chat to chat with us if you have a question for Will, and we'll incorporate it here into the conversation. Will, so if I'm, from our perspective, telehealth is tied to infection control in the sense of people don't come together, we can separate from that. But I think there's other opportunities in telehealth. Like it seems like a growing market with large tailwinds. You're talking about doctors in the US all of a sudden opening market in China. And you're also talking about doctors in the US opening market domestically. You want to tell me a little bit about those two things and how it like benefits physicians and benefits the patient?
Oh, yeah. I think that it's easy for us to comprehend how there might be a huge difference in the quality of care that someone can receive from a physician at, for example, Memorial Sloan Kettering Cancer Center and a physician at a hospital in China. Um, but in the US, we also have huge differences in the quality of care that you can access via telemedicine. I think that there's lots of valid criticisms of the healthcare system in the United States. However, if you go to the right doctor, you're going to receive the best care in the world. But a big challenge in cancer, where there's a lot of good data, is making sure the patients get to the appropriate physician. Over 80% of cancer care in the United States is delivered by local community oncologists who practice generally. So they might see 30 different patients in a day, and each has a completely different type of cancer. Whereas if you visit an academic medical center in a large city, you're going to see a doctor who handles your one specific type of cancer all day, every day. I think it should be obvious that there's a difference in the quality of care there. So with a service like telemedicine and like More Health, we can help augment your local care by connecting your local community oncologist with an oncologist at Sloan Kettering or UCSF or any one of these other great medical centers, so that they can have more insight into what are the new treatment matrices, what are potential options for clinical trials. Because these local community doctors don't have access to community trials, to clinical trials. But clinical trials are great for patients because your care also ends up being free. So if you are underinsured, then you're going to end up with free, excellent cancer care. So telemedicine is really key in delivering this higher level of care to patients suffering from critical illnesses. We also see it at Indian reservations as well, which have been some of our clients in the past. I think that the conditions on Indian reservations, they're pretty opaque to those of us who don't live on them. But if you look at like the Mojave, in the Mojave, they have 75% of homes don't have access to running tap water in their homes, which provides huge challenges for care and just maintaining regular, cleanliness at home. So telemedicine is huge for increasing the care of people rurally and those under the care of community oncologists.
Man, my head there goes to a couple places, right? It goes to as a business person, I think about the power of a niche, right? And how that helps. If you really niche down, you're really able to help specific people with specific pains. And yet, as a business person, it's terrifying because if you niche down, you feel like your market compresses. But if you can combine somebody that's really niched into a specific kind of cancer and they live in Houston, right? But now people don't have to travel to Houston to get their expert opinion because you can facilitate collaboration between the local physician who is an oncologist, but not niched into exactly that kind of cancer with the niche doctor. Like that seems like a really, really powerful cocktail, man, which I don't think people think of very much. And then the other part is the rural care, right? Like Indian reservations are a perfect example. I happen to know that physician burnout is a big thing. And in these rural areas where they have to travel long ways to visit folks in these rural areas, they got to really reduce their caseload in order to prevent them from burning out from their career. Yet with telemedicine, now they're able to reach people and not have that part and spend their time doing the thing that they have studied for so long, that they've sacrificed for so long to do, instead of being a delivery driver. All right. Like really, really powerful, man. That's really cool.
Yeah, and I know the big challenge is that there's a huge study by the National Academy of Science about 7, 8 years ago, and they said they found that everyone in the United States will suffer from a meaningful misdiagnosis in their lifetime, and the best way to mitigate against that suffering is through a second opinion.
Hmm.
Second opinions are really powerful. Even bad second opinions are better than no second opinion, because any additional observation you can have of the patient and their data, the better it is for that patient.
Yeah, that makes a lot of sense, man. Like when my brother was going through his battle with cancer, the idea of a second opinion was, we were lucky to be able to afford flying out to another hospital, doing some other things, right? Like bringing the second opinion when it's the harshest kind of like diagnoses, is absolutely a peace of mind for people. Is there data on like reduction of costs to getting second opinion, or like efficacy of care based on correlated to did you receive a second opinion or not?
Yes, there is. The data is limited. There is a big push in healthcare to say that all doctors are essentially equivalent. It's kind of a part of the mission statement of the AMA. So there is limited research, but every study that's been done does show significant cost reductions. City of Hope, which is a leading cancer center in Southern California, they use a program called Access Hope, I believe, and they found that 28% of their treatment plans and diagnoses are revised. So if you have to revise the diagnosis and treatment plan, then that means the original one would be ineffective. So if you have an ineffective treatment plan, then every single dollar being spent on it is a waste. There have also been a large study done in the past by Thomson Reuters, which looked at US healthcare spending as a whole. And they found that up to 18% of US healthcare spending is the result of overtreatment
Hmm.
and misdiagnosis. Um, but you're talking hundreds of billions of dollars at that point. So there's huge costs. There's huge cost reductions in
Yeah.
second opinions.
Yeah, these numbers, I mean, again, the parallel to infection control seems like, there's these very real numbers that are very solvable. That if it goes from 26% to like 15%, we're talking about billions of dollars of burden off of a healthcare system that's already overburdened, and are very solvable through technology, through innovation, right? Through like doing the right thing. And the ROI just makes sense. You're talking about people's lives and you're talking about dollars at stake. As you try to grow the market of telemedicine, the adoption of telemedicine, what are the biggest obstacles to getting access to, getting, I guess I'm just going to end there. What are the biggest obstacles to getting adoption in telemedicine?
Well, yeah, I think that the hospitals are looking. They're looking at two things very heavily: cost reduction and revenue generation. So, to the extent that you can show cost reduction to the hospitals, the more likely they are to adopt what you're offering. It's hard to get someone to spend without being able to prove a commensurate cost reduction. So we make heavy use of pilot programs in order to show that cost reduction and to show how it can be easier on their team. And then as far as revenue generation, if you have a way to send patients to a hospital, it can be a lot easier getting in the door and getting them to adopt your program. However, healthcare is still for example, we pay the hospitals for providing second opinions to our patients. So they're happy to generate revenue. And there's also a chance that a patient will then convert into a patient who travels to the hospital, where then a lot of revenue can be generated either through cash pay patients from overseas or just from new insurance patients locally. And then also there's always a challenge to recruit patients for clinical trials. So to the extent it can help recruit patients for clinical trials, then it can also drive adoption. But healthcare is also a very conservative field. it can be challenging for a new company to get adopted by a hospital. Typically, you have to have certain insurance requirements in place. They're looking to you as having existed for at least a few years. They want to make sure that you have strong revenue before they become a vendor of yours. So it takes perseverance and time and a track record to get adopted by a hospital. And cost savings is a great way to get in there as well.
I mean, it sounds like a great door in, this idea of we can bring you more patients if you're willing to accept patients this way, right? And then what's next? Do they need to implement some kind of like software system and then train their physicians on how to use it kind of thing? Is that like the adoption curve, or is it different?
Yeah, so for us, we developed our own platform that the physicians use to perform their second opinions, and it's really purpose built around the second opinion process. I don't know if you've ever had the pleasure of jumping into an EHR and seeing how it works, but
I have
hospitals will
not.
spend like $1 billion on an implementation of an EHR software system for their hospital, and it looks like it was built using Windows 98. They're very cumbersome. They're not user friendly. The number one point of dissatisfaction for most physicians with their practice is interacting with their EHR. So we wanted to purpose build something that is easy to use. And we've had physicians say that it's fun to use, that it boils the practice of medicine down to the most fun part of medical school, which is looking at symptoms and then diagnosing the patient without having a bunch of extra boxes to check, and just focusing on the problem itself. So we do a training, but it's an hour training. We typically train a trainer of a trainer, and the physicians don't need training. All of our tech support calls are about, I forgot my password. So it's a really nice user friendly system that our team has built.
Sounds like a great UX, man. All right. So what is I know in our onboarding call, we talked a little bit about, infection control is not your expertise, of course, right? You are evangelizing this issue of second opinions, but as you've thought through it, what do you, is there a future where this is a similar mission, right? Like where telemedicine is also saying, not just will you save costs, not just will you, increase revenue, it's also going to reduce infections. What do you think about that when I say that?
Oh, I think that if you've had a contact with the healthcare system over the past 2.5 years, uh, that makes a lot of sense. I mean, it's been hard to see a doctor over the past 2.5 years, especially a year ago, and that's because that they were worried about infection, very specific infection, COVID-19. But I think that we've all sort of learned a lesson around telemedicine and hospital-acquired infections. Um, there have been some very specific studies on it in the ICU area and also in the inpatient setting, which I just find fascinating. There was a pediatric cardiology hospital in Italy, and they implemented an inpatient telemedicine system where, and instead of seeing a doctor live at the side of your bed, they would reach out to you via telemedicine from a central room in the hospital. And over the course of that study, they found a 40% reduction in the cost of antibiotics,
Wow.
25% reduction in the amount of antibiotics used, a 31% reduction in the hospital acquired infection rate, and a 24% reduction in time spent on drug resistant isolation. Um, Similar study in Brazil found that when doctors prescribed patients antibiotics via telemedicine rather than via in-person consults, it increased the appropriate antibiotic prescription rate from 51% to 81%. In healthcare, you're typically after this just relentless pursuit of fractional improvements, but these are massive improvements in the antimicrobial stewardship programs these hospitals have in place. In the US, they found that when you use telemedicine in the ICU, I don't know if people are necessarily familiar with the ICU, but typically when you're in a hospital, it's one patient per room or two patients per room. It's easy to separate them. But in the ICU, they tend to be open, where there's two or more patients in the room and the doctors can seamlessly move between them. Well, they found that using telemedicine in the ICU rather than in-person visits lowered both the ICU and the overall hospital mortality risk related to hospital-acquired infections. It also reduced ICU and hospital stays, and it also improved the adherence to best practices in prescribing and in treating patients. So when you have the doctor, when you separate the patient and doctor a little bit, it really improves patient outcomes tremendously.
Man, those are really impressive statistics, man. You did your homework. That's a strong argument, right? Like if you're talking about cost savings or revenue generation and like these astronomical gains in certainty and efficacy, and not just barely moving the needle, but making these giant jumps. What's the argument against telemedicine?
Well, I think until recently, a big argument against it is that Medicare didn't reimburse for it. So that was the big argument against it. But there's been a big push, and there've been a lot of new bills that have been passed to bring in reimbursement to Medicare. And then also private insurance companies are beginning to reimburse more fairly for telemedicine. So the big challenge was they just weren't getting paid for it.
The latest was not getting reimbursed, but is there anything else? Is there any kind of like misconception around the idea that like the doctor can't really see you, or you need certain amount of like people in the room? Telemedicine isn't a silver bullet, right? Like anything else that we need to debunk?
I think that a big challenge with telemedicine is that it needs to be implemented well. So I was reviewing some other literature. They were doing studies on comparing various telemedicine programs in a Middle Eastern country, in which they were measuring like how did patients feel about different aspects of the consult, from scheduling through the end of the consultation, and then what would be their willingness to engage in a telemedicine consult in the future. And what they found that a high quality experience with the telemedicine made them more likely to want to do it in the future. It's intuitive, but it also helps to have the data on it to know it. I think that so long as you can collect the data, then so long as you have a good experience, a good platform, good technology, it's no problem.
I think they in your parts of Silicon Valley, they call that product-led growth, right? Like if you can get exposure to it, then there's adoption.
Right.
I love that. We got an anonymous attendee that says, I agree with the pandemic winding out. I agree. With the pandemic winding out, my wife's office is moving away from telemedicine as it isn't profitable insurance payouts. So I guess that winds of change are happening there, right? Insurance payouts are going to start happening, and maybe our attendee can tell the wife that there's going to be an opportunity there.
Private insurance is regulated differently than the public option. So it depends. It really depends. That is the challenge. It's not compensated the same.
The system. Yeah, the system. You gotta push it through the system, man. All right.
Apparently safer for us and better for us, but it's not. It's just not paid as well.
Yeah, that's brutal, man. So those are the challenges. What do you think are the big opportunities moving forward in this space? Like, what are you most excited about?
Well, I think that what I'm most excited about is collaboration. So if you're looking at inter-hospital collaboration, the state of the art right now is the fax machine. So a hospital will print out a patient's records, then they'll scan them, and then they'll fax them over, and then that hospital will print them out and then scan them and upload them on OCR into the EHR, and the physician is expected to review those records. It's absurd. It's 1980s technology, aside from the scanner, which I guess is mid 90s technology. Um, so with a service like More Health, we digitize those records and put them into a nice searchable format so that physicians can better work together to diagnose the patient, because that's another challenge in healthcare. There is no collaboration outside of a few specialized practices. Kaiser is great about collaborating, but Kaiser has its own optics problems. So when physicians, work together currently, they're just engaged in sequential note taking in their EHR. A physician will say, "I saw the patient. This happened." Next physician looks the record and says, "Okay, here's what I did with the patient." And those physicians very rarely get together in any capacity to discuss the cases. If you look at a large academic medical center, and especially in the cancer arena, they will have tumor boards, and hospitals are supposed to submit a certain percentage of their cancer cases to tumor boards. And that's where a group of doctors gets together and they look at an individual patient, and they collaborate on developing a diagnosis and treatment plan for that patient. So I think the more collaboration that we can foster for patients, the better patient outcomes will be.
Wow, man. So the opportunity to have, I kind of just like my brain short circuited when you started talking about faxes, because it's so ludicrous. So there's literally faxes just like spitting out information that people are taking paper as opposed to emailing and Zooming with people. That stuff is just not fixed. Like it's just like a carrier pigeon sending you a note and you send one back.
It is. There is some integration between EHRs, but it's spotty, and it doesn't happen very often.
Man, so the difference between somebody writing a note, sending you with a note to somewhere else, to then add to that note, sending you somewhere else, going from that to the idea that you have a team of doctors kind of like overseeing you at the same time, being able to be like, doctor, yes, right? Like, and having like a live interaction and being able to discuss what is happening with you across multiple interdisciplinary, expertises. Is that's the difference of either this or this is what we're dealing with here?
Yeah, it can be frustrating texting back and forth with three people about where to go for dinner. That's a much less complex situation than developing the correct course of treatment and diagnosis for a patient. And sometimes it's best to just get together and talk about that patient.
Yeah. Yeah. Sounds like really low hanging fruit, man. it sounds like such a no brainer. Anything else, Will? Is there anything else that I haven't asked you about that you think is pertinent to this conversation, or anything like that?
No, I think that you've done a great job, and I think that Seal Shield has a really great mission in improving antimicrobial stewardship and limiting the growth of antimicrobial resistance.
I agree with you, man. Thanks for the compliment. Will, if people want to connect with you, if they want to look more into More Health, where do they go?
They can email me at Will, WILL, @morehealth.com.
There you go. Are you on LinkedIn? Anything like that? You want to connect on the social medias?
Not really, but thank you.
Really. All right. Old school. Send him a fax. All right.
888-405-0231.
That's right. There you go. We'll put that in the show notes. The first podcast with the show notes with a fax machine. Will, man, I really appreciate you coming on. I think that this is, again, I find it to be very overlapping missions between infection control and telemedicine, and the combination of both to address very, very solvable, very impactful problems, and having somebody like you being able to come on and spit out numbers and very, very practical things that makes it so approachable is really, really valuable, man. So I acknowledge you for carrying on that mission and coming on the show.
Thank you, Papa.
Yeah. And I want to thank all of you that showed up, right? We had 10 plus people on this call. Great that you show up at Clean Talk. I promise you that the guy that you really like is going to be back next week, Brad Witchers, who I want to be like when I grow up. But in the meantime, you can check out the show on YouTube if you look up Clean Talk TV, and you can join the LinkedIn group. It's all in the chat here. It'll be in the show notes, and join us next week for another another episode of somebody who is making a difference, applying innovation, technology, and just practical, good common sense to address problems that we can solve in our healthcare system, like infection control and the benefits of telemedicine. So I'm Pablo Gonzalez, and I'm just reminding you, until next week, keep it clean.